and actually I'm the chief of the Children Neuropsychiatry unit. I declare no conflict of interest, and I try to talk about pediatric migraine without aura, my experimental data, a little discussion, and a brief take-home message. According to the neurodevelopmental stages, different stages from born to the adult age, we can observe many interesting changes in the brain connectivity and the neurochemistry of the brain, and this is the final effect of the new functional maps that can create from scholar age until about 20 years. This is the first concept to know, because it's related to the different clinical manifestation in different disease, and the migraine is one of these. About migraine, migraine is a painful syndrome that is very disabling in all age and independently from gender. And migraine is very frequent as a painful syndrome, particularly in a pediatric age. And we can distinguish a kind with aura and without aura. And the without aura, the migraine without aura is the more frequent, absolutely. And about the continuum symptoms of migraine, we can identify a premonitory phase, the so-called pre-headache, characterized by mood changes, cognitive changes, muscle pain, and food craving, particularly for carbohydrates in children. Perhaps and sometimes aura, the presence of visual or sensitive aura, and the early, so-called early headache with the dull headache, nasal congestion, muscle pain, and the advanced headache that can be identified as unilateral, starting from adolescence. And in pediatric age, differently is very frequent that the pain is bilateral and in the frontal area. Moreover, we can identify in advanced headache phase troubling nausea, photophobia, phonophobia, and osmophobia. And the final postdromic phase is characterized by cognitive change, sleep, and muscle pain. Very frequently, when we have patients with chronic headache, with chronic migraine, we can assist that the changes from pre-headache to the severe headache can be very quick. And we have also to consider that about from migraine, we can identify many triggers that are suggested, but they are not only suggested because in the clinical observation are very frequent, that can be identified in the hydration, diet, hunger, stress, and moreover, sleep disturbances. About the risk factor for recurrent migraine, we can identify the pediatric migraine, somatic symptoms, internalized disorders, sleep troubles, particularly non-REM parasomnias, sleep-related breathing disorders, restless leg syndrome, and periodic limb movement disorders, neuropsychological impairment, because migraine, according to the neuropsychological perspective, can be identified as a sort of dysexecutive syndrome, and finally the motor impairment, particularly alteration in fine and gross motricity. In this light, we can consider that particularly in pediatric age, migraine is not only a painful syndrome, because is a very disturbing and disabling syndrome. And about the relationship between pain and sleep, we have to consider that the circadian clock is very altered in migraine patients, depending from age, due to the different alteration in neurochemistry pathways, neurochemical pathways, particularly for orexin and dopamine and serotonin neurotransmission. And this is the effect, final effect of this alteration that is very typical in migraines children, that can present very frequently non-REM sleep, non-REM parasomnias, and a reduction in sleep macrostructural parameters such as the time in bed, sleep partial time, total sleep time, and a very high rate of behavioral awakening during the night, and a REM arousal index that is altered is lower than control. And moreover, when we consider the non-REM sleep instability, the so-called cyclic alternative pattern analysis, we can identify a specific peculiar aspect in children with migraine without aura. And migraine symptoms, in order to summarize what I'm trying to tell, are very articulated. We can identify the headache, vomiting, dizziness, sensitivity to weather, frequent yawning linked to the dopaminergic activation, neck stiffness, blurred vision, constipation. And about my experimental data, that it was a study approved by the University Ethical Committee. We selected 474 mothers aged between 31 and 55 age, all Caucasian, native Italian speaker, all married with stable and non-separated relationship, and we divided this sample into groups. One consisted of 237 mothers of children affected by migraine without aura, and the second one consisted in the same number of mothers, but of typical developing children. And the mothers were included if they have male or female aged between 6 and 12 years, and typical developing children, or a diagnosis of migraine without aura. Moreover, children had a history of migraine without aura of at least 6 months, a history of 14 migraine headache days, and with at least 4 migraine attacks per month, and a pediatric migraine disability assessment score, the so-called PEDMIDAS, between 20 and lower than 114 at the first visit. So we selected children, mother of children with chronic and severe migraine. We excluded mothers if their children present developmental disorders, psychiatric disorders, active and/or significant risk of suicide, and acute severe and stable medical condition. We used in order to assess the perceived stress of mother. We used this tool that the parental stress index, this short form, the Italian version of the parental stress index, that is a standardized self-administration questionnaire that can provide 3 different scales: parental distress, parent-child interaction, difficult of child, And the subscale, each subscale can be scored from 12 to 60, and the total stress score ranges from 37 to 180, and high score means great parental perceived stress level. Moreover, we used the PED-MIDAS, the Pediatric Migraine Severity Assessment, that is a validated tool screening to assessing migraine disability among school-age children, with 6 questions that investigate the impact of migraines on daily activity. And this is the one the more validated and probably reliable for assessing migraine-related disability in pediatric age. And we can distinguish about the score range in the mild from 11 to 30, in moderate from 31 to 50, and greater than 15 is a severe grade of disability. About statistical analysis, we performed the independent t-test to compare the 2 groups and the correlation analysis. So these are the findings of our study, and you can easily identify the statistical significance in all scale of PSI between mother of children with migraine and without migraine. And this very interesting is, according to my opinion, is the second tables, because there is a correlation between the frequency, intensity, and the PED-MIDAS. Again, please, I'd like to stress this column, because according to the new criteria for the COINS, the analysis of correlation, as you can easily identify, the stress total score is very high as the parent-child interaction. What means? Okay, we can imagine that there is a suggested relationship between the subjectively perceived maternal stress and the frequency, intensity, and grade of disability, and the clinical management of migraines, particularly in developmental age, is complex, and impact involves the whole family. Honestly, my study is not novel. It's not new in the field of migraine in pediatric age, because there were all other study assessing the parentic stress level in mother or in parents of children with migraine without aura, and but all these studies assessed a higher rate of stress in mother of children with migraine without aura, with the interesting speculation about hypothesis about the effect. For example, there is a sort of rejection due to the child's pathology, situation that can generate feelings of helplessness in the parent. And in this way, it can be interpreted, the parent-child interaction domain altered in the 2 groups. Moreover, relevant suggestion about the importance of coping strategies in chronic disease, considering the significant negative impact of children, their lives, and their family. And this may explain the higher values in the parent-child interaction and difficult child subscale among mothers of children without aura. Novelty of this study is can be summarized in the fact that this correlation analysis between maternal stress level and the frequency, intensity, and duration of migraine attacks. The degree of PED-MIDAS that seems very strongly related to the parent's total stress level, and but the duration of migraines episode is not related to the stress level. Finally, the take-home message is that the correlation between frequency, intensity, and disability degree and maternal perceived stress level is relevant and can be related. Each chronic disease impacts the quality of life in family and children affected, causing a specific condition in pediatric age, with psychological troubles also in maternal-child, mother-child interaction, and children with affected by migraine may be more likely to be assessed also for psychological aspect, and they need a behavioral intervention to improve stress, the personal perceived stress, and with the assessment of the stress level and the coping strategies for treatment also for parents. Thank you. Thanks for your attention.